Welcome back to the Orthopedic Tutor channel. If you haven't watched my video regarding the shoulder impingement and calcific tendinosis, I suggest you do so because this video is a continuum of those videos. As you can see here, that rotator cuff tear is actually a part of a continuous condition starting from impingement, going through to the subacromial impingement, and then rotator cuff tear happens, and which will ends up with the rotator cuff arthropathy. Now this rotator cuff tear session will be divided into two videos. The first one will discuss the basics and diagnosis, and the next one will discuss about the management and post-management programs. Now, moving on to the basics of rotator cuff. We all know that rotator cuff occur in specific populations, and the incidence is usually 25% of the cases have in more than 60 years old have full thickness tears, and 65% of populations with more than 70 years old have full thickness tears. And there are specific risk factors that may preclude to the formation of this condition, which includes the age, smoking, hypercholesterolemia, and also family history. The rotator cuff tear is also associated with certain conditions such as AC joint pathology, which has been discussed previously in the subacromial impingement. The AC joint pathology may decrease the space available under the acromion and therefore leads to impingement, which later on develops into a tear. It could also be associated with other conditions such as biceps pathology and internal impingement of the shoulder. Well, the definition of rotator cuff tear itself, it is a tear that involves the rotator cuff structure, and it is a second stage within the rotator cuff disease. We all know that the impingement is what starts it all, and the partial and full thickness tear is what follows, and massive rotator tear may occur following partial or full thickness tear, followed by rotator cuff arthropathy. Now, the rotator cuff has also a very specific footprint. The supraspinatus, which is one of the most frequently associated rotator cuff that is torn, has a footprint over at the anterosuperior aspect of the greater tuberosity. As you can see here in this image, this is the footprint of the supraspinatus. This is the supraspinatus, and this is the footprint. It covers the superior facet of the greater tuberosity. Next, we can see that the rotator cuff itself also have histological areas. The rotator cuff tendon has 5 distinct histological layers, and these layers goes from the most superficial to the deepest layer. The first layer, or the most superficial layer, is around 1 millimeter thick, and it is composed of fibers from the coracohumeral ligament, which extend posteriorly and obliquely. While moving on to the deeper layer, we could see that the layer that is closer to the bone has more organized bundles of collagen, and it also has mixture of some loose connective tissues and thick collagen bands that converge and merge with the fibers of the coracohumeral ligament. And in the deepest layer, you could see that the shoulder capsule is also part of the rotator cuff layers. Now, the blood supply of the rotator cuff comes from several sources, while most of them goes to the area between the second and the third layer, the subscapular, the suprascapular, and the humeral circumflex arteries. And knowing this, we could say that usually the bursal side is more vascular than the articular side, because remember once again that the layer goes from outwards to inwards. So between the layer 2 and 3, that is the layer that is closer to the bursal side, and the 5th layer is the layer that is closer to the articular side. Let's go take a look at this image. This is the histological area, and the vascular goes around here. And that is why the areas around here, or the bursa of the subacromion, is the areas of tendon that is more vascular compared to the areas here. Knowing this has an impact on the treatment choice. We will discuss more about that in the next video. Now, afterwards, you need to know what may cause the rotator cuff tear. Actually, there are several causes, but these are the most common ones. It all started from the chronic impingement syndrome that you could review in my previous videos. The chronic impingement syndrome may cause changes over at the bursal site or at the tendon substance. The tear itself could also be a degenerative one, which initiate as a minor tear along the substance of the tendon, which accumulate over the years and cause chronic degenerative tear. It could also be part of an acute injury, and it could also be caused by the doctors who are performing the surgery or iatrogenic. Well, tension failure of the rotator cuff is usually situated at the articular surface. Well, knowing all of that, you need to be able to classify the rotator cuff that has occurred. I find that classifying it based on the pattern is the easiest type because it is based on the shape, and the treatment later on is also based on it. So the cuff lesion could be a crescentic type of lesion, a U-shaped type of lesion, an L-shaped type of lesion, or a massive contracted type of lesion. Here is some of the example of types of tear. Here we can see the normal supraspinatus cuff, and we could see this is a partial thickness articular sided tear, and this is a bursal sided tear. I'll zoom it for you. This is a bursal sided tear. This is an articular sided tear. It could also be an interstitial tear. Other patterns of tear includes the pasta, or the partial thickness avulsion of the supraspinatus tendon. It could also be an attritional wear due to abrasion to these structures. It could also be a full thickness tear with retraction, or intramuscular cysts could even form within the tendon substance. This is the last pattern. You could see that there could be a partial thickness articular sided tear with delamination and retraction of the fibers that is situated at the deeper areas of the tendon, also known as the pain lesion. Well, knowing all of that, let's go back to the classification based on the pattern. I would suggest that you remember this one because it is quite simple. So the pattern could be divided into a crescent type, U, L, or massive type. Like in this picture depicted here, you could see that this is a U-shaped type of rotator cuff tear that is later on repaired through surgery like these, and we will discuss about these later on the next video. And this is a L-shaped type of tear. We could see that there is a tear over at the attachment and also at one of the sides of the supraspinatus, the anterior side, and it has an angle and therefore an L-shaped type of tear. It could also be a crescent type of tear occurring at the center of the insertion location, and it could also be a massive contracting longitudinal tear. Well, each of these types of tear have their own specific methods of repair, so you need to get used to knowing these types of injury. One of the other classification scheme that is proposed by DeOrio and Caulfield, which classify them based on the size of the lesion. They classify it into a small lesion, a medium lesion, a large lesion, or a massive lesion, which has retraction of over than 5 cm or involving 2 tendons. Well, after you have known all of those basics, you need to know how to make the diagnosis of a rotator cuff tear. It all starts from history taking, and patients often come with complaints of pain situated over at in the deltoid region, and there should be pain and limitation. that is insidious and is triggered by any overhead activities. There might also be some night discomfort along with muscle weakness. While knowing all of that, you need to know that it is very special to remember the basic anatomy of rotator cuff in order to do or perform a good physical examination. Because in first evaluation of the range of motion, you need to differentiate between the active and passive range of motion, because in the rotator cuff disease there will be an intact passive range of motion with loss of active range of motion, because basically there is nothing wrong with the joint. So when you move the whole limb, the joint should be functioning well. But when you ask the patient to actively move by themselves, since there is some trouble in the muscle, the patient is unable to move the whole range of motion. Next, evaluation should include muscle weakness. And to do this, you may be confused sometimes while reading textbooks regarding physical exam for the rotator cuff, and I find this table to be very good and it summarizes all the important points. So in doing a good physical exam for the rotator cuff tear, you must evaluate each muscles individually, starting from the supraspinatus, infraspinatus, teres minor, and subscapularis. I usually do it one at a time because I do not want to mix up between all of these tendons. So I usually start with strength testing, then I do special tests. So when I evaluate for supraspinatus, I find out if there is any weakness to resisted elevation in the job position, followed with the job test. And next, for the infraspinatus, I perform it with the patient in their upper limb position in 0 degree of abduction, and I try to look for any external rotation weakness, followed by the special test of external rotation leg sign, and so on for the teres minor and the subscapularis. I find this table to be very good because it is not misleading. It allows me to evaluate each of the muscle individually, and I could localize the problem and I could point out which rotator cuff muscle is troubled. And next, afterwards, you need to know all sorts of special tests that is being done, because a complete physical exam of the shoulder does not only include the rotator cuff. As you can see here, that based on this table, a good shoulder physical examination should include examination of any signs of impingement or rotator cuff, but also at the same time you need to evaluate for any signs of instability or any pathology at other sites such as the labrum or the biceps. Only by doing so you could exclude all the differentials and lead to the diagnosis of these rotator cuff tests. Now, after knowing all of that, you need to get yourself familiar with the additional examination that can be done to diagnose this condition, and these include plain radiographs. During the plain radiographs, you can see classic changes in the acromion or the coracoacromial ligament, especially if there is an association with type 3 acromion. If you haven't got a clue of what type 3 acromion is, you should watch my video, the previous video regarding the subacromial impingement. Next is the acromiohumeral distance must be measured, and there could be any appreciated cystic changes over at the greater tuberosity, followed by superior humeral migration due to the dysfunction of the supraspinatus tendon in maintaining the proper relationship between humerus and the glenoid. There could also be degenerative changes such as calcific tendinitis. Now, the USG or ultrasonography can show us some tear at some location, and it could also help us confirm the location of injection and if it is to be done. Now, arthrogram is usually done when MRI is indicated because MRI is definitely our go-to test. The key to MRI is to find any fatty infiltration. And fatty infiltration of the muscles means that the muscle is atrophic and there is changes. The muscle is no longer muscle and there could be degeneration and changes into fatty tissue. And Gottelier here classify the fatty infiltration that is present in the rotator cuff musculature. There is also other classification based on the Fuchs, or there could be also another classification that is descriptive, where you just mention how much muscle and fat there is in the MRI. Well, all of that is good. You need to know one of the signs that is frequently sometimes asked in the exam, which is the tangent sign. Positive sign means that the rotator cuff is an irreparable rotator cuff tear. Now here is an example of the signs you can see. This is the scapula and this is the spine of the scapula. This is the supraspinatus muscle and infraspinatus muscle and teres minor muscle. And you want to pull a line here that goes from the superior border of the coracoid to the superior border of scapular spine. And if the muscle belly is still able to cross this line to the superior aspect, then we consider the muscle to be in a good condition. And if the muscle does not cross this line, then it usually correlates, such as this one. You can see the dark gray picture here depicting the muscle. Then this correlates with muscle atrophy, and these are the signs of fatty infiltration along inside the muscle. And this is one of the signs that shows us this is an irreparable muscle tear, because of the quality of the muscle is very poor already. You could see here in one of the graphics shown that the muscle is only below the line. Next, after knowing all of this, you need to get yourself accustomed to detecting if there is any abnormalities in the MRI. Remember that the normal tendon should have no increased signal. Any increased signal would mean that there would be an accumulation of fluid or signs of inflammation over at that area. And getting yourself used to these MRIs will make you keen or make you more accustomed to reading MRI. And these are one of the examples that you could see here. These are the pictures here showing that there's a thickening of the supraspinatus tendon. Here over the C, you could see an increased signal here, as I've mentioned earlier. This increased signal over at the articular side of the supraspinatus tendon. It means that this supraspinatus tendon's insertion is already partially destroyed. So this is a partial articular side supraspinatus tendon avulsion. And here you could see that the whole footprint of the supraspinatus tendon is filled with this increased signal. This signal usually increase due to the increased number or amount of fluid, and this will show you that there is already a full thickness supraspinatus tear with retraction of the tendon. The tendon is no longer attached to any of the footprints here. That would be all for today's presentation. Be sure to log in and watch the rotator cuff part 2, which will include the discussion of the management of rotator cuff and post-management of the rotator cuff tear. Don't forget to subscribe to the Orthopedic Tutor channel for more videos. Thank you.